This patient is one of millions around the world suffering from atherosclerotic cardiovascular disease. He's undergoing a full array of diagnostic tests to determine the extent of his illness. But if there were some reliable way to prevent the development and extension of coronary atherosclerosis, patients like this would be spared the terrible morbidity and mortality that results from this common and devastating disease. Over the past 3 decades, epidemiologists, pharmacologists, and physicians have all been searching for ways to prevent atherosclerosis, and we've made great progress. Today we know that lifestyle changes, lowering blood pressure, controlling blood lipids, and altering other risk factors all help prevent ischemic heart disease. Interestingly, another line of research on the prevention of heart disease has also evolved over the past decade, but with very little attention. This has been the role of calcium in atherosclerosis. It's well established that calcium is essential for life and essential for the proper functioning of the myocardium. Calcium performs not just one, but a variety of functions in both the myocardium and the myocardial vasculature. For this reason, the calcium channel blocking drugs alter several important cardiovascular functions, such as reducing vascular tone, lowering blood pressure, and reducing oxygen demand. But calcium has other important functions, and some of these appear to play a role in the formation of atherosclerotic plaques. In this program, we'll examine the evidence that's been accumulating over the last 20 years of calcium's effect on atherosclerosis. We'll be talking to some of the leading clinicians and investigators in this exciting new field. Most importantly, we'll look at the most startling implication of their research, that calcium channel blockade may reduce the development of new atherosclerotic lesions in coronary arteries.
Surprisingly, there is very little data collected on composition of atherosclerotic plaques in the coronary arteries. My colleague, Dr. Amy Craigle, and I recently have been examining atherosclerotic plaques in coronary arteries in patients with fatal cardiac arrest, with fatal acute myocardial infarction, and in patients with unstable angina. And we've been examining these coronary arteries by dividing them into little bitty 5-millimeter segments, and then by a fancy planimetry setup, Dr. Craigle has planed out the amount of each component in these atherosclerotic plaques. There are about 54 5-millimeter segments to examine in each patient. So it's a very complex thing. But the thing that's interesting, what we found was that 80% approximately of the atherosclerotic plaques in the coronary arteries of all these 3 subsets of patients that we've studied consists of fibrous tissue. Now, of that 80%, about half of it is cellular fibrous tissue, and the other half is very dense fibrous tissue, which is acellular. That leaves about 20% of the plaque to consist of components other than fibrous tissue. Now, that 20% was made up of lipid, mainly extracellular lipid, and calcium, and some miscellaneous materials. But lipid made up, as a rule, on an average, about 8% of the plaques, and calcium about 8%.
Atherosclerotic plaques are not static lesions. Through research from Dr. Roberts and other labs, we know that the calcium component of plaque actually increases with an individual's age. Although there are many theories, one current concept is that a plaque develops as a result of an injury to the vascular endothelium. In an apparent effort to repair this damage, platelets and monocytes attach themselves to the injured wall. The platelets aggregate around the injury, while the monocytes or macrophages invade the intima and begin to scavenge for lipids and other extracellular materials. In the process, these cells release a variety of growth factors which attract smooth muscle cells from the media of the artery, resulting in intimal hyperplasia. Thus, the stage is set for the proliferative process which results in a fully developed plaque. As it continues to evolve, the plaque may rupture, leading to thrombosis and occlusion of the artery. We're aware that in this process, lipids are taken up by the macrophages and become incorporated into the plaque as fatty streaks. But where does calcium fit into this picture? The answer is not readily apparent, but intensive research has shown a number of possible sites of action for calcium in the formation of a plaque.
There have been several studies in which there appears to be a well-documented inhibition in experimental animals of the development of atherosclerotic plaques. This would then give a rationale for testing these agents in man in clinical trials to determine whether they exert a similar effect there.
The effect was first suspected in the 1960s and 70s, when researchers found that calcium chelating agents and inorganic calcium channel blockers could suppress the formation of atherosclerotic plaque in animals. In 1981, these important studies were augmented by the work of Dr. Philip Henry. He fed rabbits a high cholesterol diet to induce atherosclerosis and gave one group nifedipine and the other placebo. After 8 weeks, the placebo group was found to have 40% of their aortic intimal surface covered with lesions, compared to only 17% in the nifedipine-treated group. The cholesterol concentration in the aortas of the control group was found to be 47 milligrams per gram of protein, significantly higher than the 29 milligrams per gram seen in nifedipine-treated animals. These differences were achieved without altering the serum cholesterol in either group. Dr. Henry's conclusion: in animals, nifedipine suppressed atherogenesis without reducing hypercholesterolemia. Before we go further, we should stress that all of our investigators have pointed out that these studies on calcium and atherosclerosis do not in any way diminish the importance of reducing cholesterol, either by diet or by lipid-lowering drugs. Since the work of Dr. Henry was published in 1981, over 50 animal studies have been conducted to clarify and expand upon Dr. Henry's findings. The majority have found a similar effect. Calcium channel blockade can prevent the growth of new atherosclerotic lesions. Thus, the stage was set for clinical trials. To date, at least 3 trials using nifedipine have been completed. A trial comparing nifedipine, propranolol, and isosorbide dinitrate in stable angina patients, conducted by Dr. Guazzi and co-workers in Milan, Italy. The INTACT trial, a multi-center trial comparing nifedipine with placebo in patients with coronary artery disease, headed by Dr. Paul Licklin of Hanover, Germany. And a trial comparing nifedipine and placebo in bypass graft patients, conducted here at the Johns Hopkins University School of Medicine in Baltimore.
I believe most of the early animal work that demonstrated a positive effect, and the most impressive studies in animals, did use nifedipine. And when these particular studies that we're talking about, the clinical trials, were launched relatively early in the 1980s, we had to hedge our bets and try to pick the agent that had been really demonstrating the most favorable benefit in animals. It makes sense to utilize that approach.
Dr. Gottlieb and his co-workers chose to study bypass graft patients because a large majority of these patients develop atherosclerotic lesions, particularly around sites of anastomoses.
Well, when we were contemplating studying the idea of atherosclerosis suppression with calcium antagonists, we wanted to choose what we considered the most high-risk subgroup, that group which is very likely to develop atherosclerosis over a short period of time. Now, we decided that a subgroup appropriate to study would be one with multiple ongoing atherogenic risk factors, such as ongoing hypertension, smoking, hypercholesterolemia, etc. Then an accelerated model, human model of atherosclerosis, is the coronary bypass graft, the saphenous vein graft, which pathologically, when examined over time, shows changes very similar to native atherosclerosis in the native coronary arteries.
Candidates for Dr. Gottlieb's study had 2 or more coronary risk factors and recent coronary artery bypass grafting. In all, 144 patients were enrolled, and their clinical course was followed for 1 year. Half of the patients were randomized to nifedipine, 60 milligrams per day, while the other half received placebo. All patients were placed on standard antiplatelet medication, including aspirin and dipyridamole.
The angiograms were reviewed blindly by 2 experienced observers without knowledge of the patient identity or the patient study drug assignment. The angiograms were looked at in terms of the presence or absence of lesions in the bypass grafts. The bypass grafts were determined to be, it's obvious, you can tell if they're totally obstructed, but then if new lesions were apparent, these were quantitated and noted down. When we looked at the angiograms at 1 year after bypass surgery, what we found is that the group assigned to placebo, only 52% of these bypass grafts were entirely free of disease. As compared to the group that received nifedipine, 67% of those grafts were free of disease. So it appeared that in fact, we were successful in choosing a high-risk population, and in that population, the treatment with the calcium antagonists appeared to suppress the development of new lesions.
Exercise tests were performed on all patients 2 months into the study. 16 placebo patients had positive stress tests, which was significantly higher than the 6 nifedipine patients with positive tests.
But of course, we know that's also an anti-ischemic agent, so that might be, the particular effect on the exercise test might have been mediated in that regard, as opposed to atherosclerosis suppression, because that only at 2 months would be perhaps too soon to see that effect. But when we did look at the incidence of myocardial infarction, there were only 3 infarctions that occurred. All of them were in the placebo group, none in the nifedipine group. Now, that number of events is too small to reach statistical significance, but it is a suggestion, perhaps, that if we looked at a larger number of patients over a longer period of time, we might see a lowered infarction rate, we might see a lower mortality rate. These are things that have yet to be determined.
The conclusion Dr. Gottlieb and his co-workers have drawn from this study is that in this high-risk subset of bypass graft patients, nifedipine appears to have a beneficial effect on the development of atherosclerotic graft lesions.
So I think we have early evidence that the calcium antagonists can suppress atherosclerosis in different subsets of patients with known coronary disease. And we'll have to see with large-scale, long-term clinical follow-up, new trials, whether this results in clinical benefit.
In Milan, Italy, another trial examining the effect of nifedipine on atherosclerosis has been underway. Dr. Maurizio Guazzi heads the Department of Cardiology here at the University of Milan. With his co-workers, Dr. Guazzi recently published this article in the American Journal of Cardiology, summarizing the results of their 2-year trial. Dr. Guazzi also became interested in pursuing clinical studies after reviewing the results of the animal data on nifedipine.
And if we were able to utilize drugs having anti-anginal effects or anti-hypertensive effects together with benefits on the coronary atherosclerosis, it would be a real advance in the treatment of the 2 diseases. This is the reason why we became interested in the calcium channel blockers and coronary atherosclerosis in men.
While the Johns Hopkins investigators examined bypass grafts, Dr. Guazzi and his associates chose to investigate native coronary arteries. To ensure that the trial contained patients who were likely to develop coronary artery lesions, they selected patients with recent onset, stable, classic effort angina. An arteriogram had to document a focal lesion of greater than 50% without total obstruction in a major coronary branch. None of the patients were to have undergone previous anti-anginal therapy. Excluded from the study were patients over 60 years of age or with previous MI, bypass graft, normal coronary arteries, valvular disease, hypertension, left ventricular hypertrophy, diabetes, or other life-threatening extracardiac disease.
for such a study to be informative, we should have middle-aged patients with possibly an initial stage of the disease. Because, of course, if several vessels are already severely involved, the evolution of the disease might be just artificially less than in patients with an initial stage of the disease. And this is the reason why we looked for patients, middle-aged patients, with an initial stage of the disease and without severe manifestation of the coronary artery disease. That means angina pectoris in the classic effort form of recent onset and not particularly severe.
Between 1983 and 1986, Dr. Guazzi and his colleagues enrolled 1,957 subjects, of whom 113 met the entrance criteria. All patients underwent baseline angiography and were then randomized to one of three treatment groups: isosorbide dinitrate, which is known to have no effect on atherosclerosis and therefore served as control; propranolol, which some animal studies suggested might have an anti-atherosclerotic effect; and finally, nifedipine. All patients remained on the study drug for a minimum of 2 years.
We tried to have three very homogeneous group of patients, homogeneous as regards gender, age, severity of angina, and mainly severity of the coronary involvement as evaluated through quantitative coronary angiography.
A computerized technique of measuring arterial luminal diameters was used for quantification of both baseline and follow-up angiograms. The angiograms were first put through a filter to clarify the image. Then measurements were taken of the injection catheter and the widest and narrowest points of the involved artery. The computer then calculated the artery diameters, which were calibrated based on the known width of the catheter. With these, precise measurements of each coronary lesion were made, aiding in the comparison of baseline to follow-up studies. The analysis was conducted by observers who were unaware of which patient or angiogram was being analyzed. All angiograms were assessed for progression, regression, and steadiness of the disease. In the analysis of progression, 47% of the nitrate-treated group, 53% of the propranolol-treated group, and only 31% of the nifedipine-treated group were found to have progression of the disease. Thus, the nifedipine-treated patients had significantly less lesion progression than either of the other groups. In addition, in those nifedipine patients whose disease did progress, the changes in lumen diameter were less than in the other two groups. 18% of the nifedipine-treated group experienced regression of atherosclerotic disease during the trial. Although small, it was significantly greater than the disease regression seen in either the propranolol or nitrate groups. Steadiness of the disease was also found to be similar in all three groups: 51% in the nifedipine group, 39% in the propranolol group, and 45% in the nitrate group. The investigators also found that coronary risk factors did not change over the study period, or were the same for all three groups. Most plasma lipid concentrations were normal at the outset of the trial. However, at the end of the trial, the propranolol-treated group had a 28% increase in total triglycerides and a 25% decrease in high-density lipoproteins, which were statistically higher than both other groups.
Whether this might be the reason for a more progressive pattern of the disease or whether some other reason is involved, obviously we don't know.
No unusual side effects were noted in any of the groups. 2 patients in the nifedipine group and 2 in the propranolol group suffered myocardial infarction during the study. There were no deaths.
The data speaks in favor of an anti-atherosclerotic effect, indicating possibly that calcium channel blockers should be the drug of first choice. But this is not a statement, this is just a suggestion.
For our final look at nifedipine and atherosclerosis, we return to Germany. Here in Hanover at the Medical University, Dr. Paul Licklin has just completed the largest clinical trial to date investigating the use of nifedipine in controlling the development of atherosclerosis in native coronary arteries.
It was clear from the animal studies that one should not start with patients who have very diffuse advanced coronary disease, but that probably one should look at the first step at the development of the real small lesion. And therefore we included mainly patients who have an early stage of coronary artery disease. That means patients who either have become manifest with a single coronary lesion, which was undergoing balloon dilatations, for instance. About 30% of our patients had balloon dilatation, but where we knew they had the disease, or who had a single small myocardial infarction.
Working with 9 medical centers in Germany and the Netherlands, Dr. Licklin enrolled a total of 425 patients who were randomized to either placebo or nifedipine, 80 milligrams per day, for 3 years. Baseline and 3-year follow-up angiography were performed. The angiograms were analyzed using a computer-based system which measured coronary artery diameters.
One can see clearly the edge lines drawn by the computer, and in the middle also the edges of the concentric stenosis, and what it is shown in white, the plaque areas. And from this one can then also calculate the minimal diameter and of course percentage diameter, area stenosis, and so forth.
Patients were not excluded from the study if they were on other cardiac medications. For example, 30% of the patients were on nitrates, 25% were on beta-blocking medications, and 15% on antiplatelet medications. But there was no difference between treatment and placebo groups in this aspect. A total of 143 patients had to be withdrawn from the study for various reasons. Of the 282 remaining, 148 were on placebo and 134 were on nifedipine. The trial looked at both regression and progression of the disease. No differences were seen between the groups with regard to progression of the disease.
That means both groups showed the same amount of progression in stenosis, in minimal diameters, and so forth. However, it was very interesting that this progression was clearly less than we had anticipated. The progression of existing lesions was only about 17% per year and not the 30% we had expected.
In 49% of the placebo patients, 118 new lesions were noted, or 0.8 lesions per patient. This was statistically higher than the nifedipine group, in which 40% of patients developed 78 lesions, or 0.58 lesions per patient.
However, the big difference, the significant difference, was in the new lesions. In the new lesions, and we included only lesions more than 20%, that is, segments who had no or looked completely normal on the beginning, had no changes, and then segments who after 3 years showed a clear-cut new lesion more than 20%. There we had a differences of 27%. And what was more striking, in the left anterior descending branch, the difference was 40%, and in the left circumflex branch it was 38%. So in these branches, especially in the left anterior descending branch, who is perhaps the most important one, we had a 40% difference. From these findings, we can draw several conclusions. First of all, the INTACT study clearly demonstrated that the results found in animals could also be produced in man. So that must be a phenomenon underlying the whole study, which is occurring in animals as well as in man. That means that, first of all, the animal studies were correct and can also be followed and should be followed to really clear the mechanism. And on the other hand, the study in man being so positive should also be followed maybe with other drugs. Second, we feel, or we are very much encouraged that calcium antagonists indeed are another way to prevent coronary disease to a certain extent. However, the study showed that one has to start very early. If an artery is already very advanced diseased, then it seems the calcium antagonist will not work anymore, or to a much lesser degree.
Because of these remarkable findings, the search will undoubtedly intensify for the mechanism which would explain this reduction in new lesion formation. Efforts continue in this area worldwide.
Well, I think that we don't have a final answer, as is usually the case for most clinical trials. But the trials do suggest that in individuals who may be prone to develop lesions, that the use of a calcium antagonist such as nifedipine may prevent this process, or may impede it, or may slow it down. We now have a consistency in finding from animal data to human data. And so this is another, while it's not at this point a proven mechanism or a proven therapy of value, the cardiologist should be aware of this. And so in considering an individual patient who may be prone to develop atherosclerosis or may already have lesions, and one wants to keep the patient from developing new lesions, this is another approach that the cardiologist can consider.
Milestones in Medicine is produced by American Medical Video, which is solely responsible for its content. This Milestones in Medicine program is funded through an educational grant provided by Pfizer Pharmaceuticals.